MVP in all of healthcare is norepinephrine, famously known as Levo or Levofed. This medicine acts at the adrenergic receptors, mainly alpha-1 to vasoconstrict, and then a little bit at beta-1 to give it some inotropy. Next up, we have vasopressin. This is a V1 receptor agonist, which causes vasoconstriction independent of the adrenergic system, which to me is huge, right? It kind of gives the body this breath of fresh air because a lot of our pressors are really acting at the adrenergic system, and to have this other med that's acting on a completely different system can be really effective whenever you're adding it on. The dose is not titratable, whereas Levo is a titratable dose. Next up, we have epinephrine. This acts at alpha-1, beta-1, and beta-2. There's a dose-dependent balance. This is indicated whenever you have refractory septic shock, or think about cold shock with low cardiac output. The risk of this one is tachyarrhythmias, myocardial ischemia, and a lactate rise. And this is from acting at the beta-2. It's not really just hypoperfusion here. But this is a great rescue pressor if Levo and Vaso isn't enough. Next up, we have dobutamine, which is an inotrope. This acts mainly at beta-1 and a little bit at beta-2 to increase contractility. The risk here is that you usually get a bit of vasodilation, kind of refractory to that. So think about it whenever you have low cardiac output shock. The risk here is that it can worsen hypotension and there's risks of arrhythmias. Next up, think about phenylephrine. This is another pure vasoconstrictor type med. So it's a pure alpha-1 agonist, whereas Vaso is at the V1 receptor, but it causes vasoconstriction only. It's indicated in septic shock with a tachyarrhythmia when Levo and Epi are not tolerated. The risk here is that you can decrease your stroke volume and your cardiac output, have a reflex bradycardia, and also cause ischemia. So adding this medicine in is basically giving your body the cortisol it needs to maintain vascular tone, potentiate catecholamine responses, and modulate inflammatory responses. The dose is 200 milligrams a day IV. You can do 50 milligrams every 6 hours or continuous infusion. There are risks to this medicine though that you should always be thinking about. So hyperglycemia, you can increase infection risk because it's an immunosuppressant. You can give these patients myopathy and even lead to GI bleeds. Your order of use should be start norepinephrine or Levo. This is first line. You can add Vaso. This is a background fixed dose. If the Levo is climbing to 0.2 or 0.3 micrograms per kilogram per minute, then you can add epinephrine if the MAP is still low, especially in a cold shock. Think about dobutamine if the echo shows poor contractility but the MAP is supported, and then consider phenylephrine if tachyarrhythmias. Limit your Levo and your Epi doses.